I now have the great pleasure to introduce to you Dr. Thomas Scalea, who will give the Roger T. Sherman Lecture. This lecture is named for Dr. Roger T. Sherman to honor his contributions to the Congress, the field of surgery and trauma. Dr. Sherman became a member of the Congress while still a resident and presented one of the first gold medal forum papers. He was president of the Congress in 1984 to 1985 and was named secretary director in 1986. He served in that capacity until 1993. Dr. Sherman was Whitaker Professor of Surgery at Piedmont Hospital and Emory University School of Medicine when he retired in October 1997. Dr. Sherman passed away on April 9th, 2006 at the age of 82. Dr. Scalea will present the past, present, and future of endovascular care for trauma. Dr. Thomas Scalea was born in Rochester, New York. He attended the University of Virginia and subsequently received his MD degree from the Medical College of Virginia. Dr. Scalea completed his residency at the Upstate Medical Center in Syracuse, New York, and critical care fellowship at New York Medical College. Following his fellowship in 1984, Dr. Scalea began his career at the Kings County Hospital Downstate Medical Center in Brooklyn, New York. He became chief of trauma and critical care and rose to the rank of professor of surgery in 1991. While directing the trauma center at Downstate, he also founded the Department of Emergency Medicine at Downstate. In 1997, Dr. Scalea became the physician-in-chief at the R. Adams Cowley Shock Trauma Center at the University of Maryland Medical Center, the nation's only freestanding trauma hospital. Several years later, 2002, he became the first medical school endowed professor of trauma when he was appointed the Honorable Senator Francis X. Kelly Professor in Trauma Surgery Award. In 2012, Dr. Scalea was named System Chief for Critical Care Services at the University of Maryland Medical System. While serving as the director of the Trauma Center, he has maintained a continued strong commitment to teaching all medical personnel to include medical students, residents, fellows, attending physicians, nursing staff, and U.S. Air Force personnel. Our Critical Care Fellowship is the most competitive in the country. At Shock Trauma, he has directed clinical, educational, administrative, and research overhauls, including an increase in clinical volume of 40% over the last 15 years. Dr. Scalea is really an amazing surgeon, and we've been lucky enough to have some of his graduates of the Shock Trauma system be professors and attending physicians at our own trauma center. And I give you Dr. Scalea, who will present this lecture.
Good morning. It's indeed a pleasure to give the 2021 Roger Sherman Lecture. I spent some time researching Dr. Sherman, and everybody had the same wonderful things to say about him. He's impeccably trained, soft-spoken, proper, always nicely dressed, and all recall his legendary AAST presidential address on the management of splenic injuries. He's described as a true mentor and educator. I actually met him in 1983, soon after he arrived in Atlanta, when I was interviewing for a fellowship here. Rich Mullins was the current fellow. He was my host, and I still remember sitting in his office, a lot of dark wood, talking to him about coming to Grady. Of course, he didn't actually hire me, but he said there was no longer any funding. I hope that was actually true. We'll start with evolution, the process of growth and development. This starts, as far as I can tell, in 1972 with this New England Journal of Medicine article, 3 patients with pelvic fractures who had angiographic localization and 2 had embolization for pelvic fracture bleeding. Now that made a lot of sense to all of us as it allowed us to avoid opening the hematoma. But extrapelvic embolization was really very slow to be accepted because real surgeons looked on this as weak-minded because we operated. That's what surgeons did. But then CT replaced surgical exploration in many cases, and a couple of people in Brooklyn began to dream. This is Sal Sclafani, a interventional radiologist who was more like a surgeon than many, and Jerry Shafton, a general surgeon who believed that trauma surgeons should fix everything. We fixed fractures when I first started at Kings County Hospital. We started with the spleen. This is a very early splenic embolization picture. You see the huge coil coming out in the splenic artery. And this is a 1984 post-embolization picture. And you can't even see the coil because there is such rich collateral flow through the pancreas and the short gastrics. This is the 95 first series on splenic artery embolization. There is a 98.5% splenic salvage rate. I believe still the best results ever reported in the literature. Fast forward 35 years and you come to today in Baltimore. This is our recent data, 200 consecutive splenic injuries, highly protocolized. We do a lot of surgery for splenic injuries, but 36% are embolized and we had a 0 failure rate. Why is that? We got a lot of volume, we are highly protocolized, and we do a lot of surgery. We did 20% splenectomies after CT scan because they had one episode of hypotension. They needed some blood. They had a change in exam. Or I walked in and looked at that and said, you know, that's just not going to be okay. Let's not observe this patient. And we operated because we operate on terrible looking CT scans, even in stable patients. Now we move from the spleen to the liver, and this, of course, is a very different set of circumstances because if splenic embolization fails, you take the spleen out. The liver is more complicated. And so hepatic embolization became an important part of the early phases of damage control. And embolization can be pre-op, post-op, or as an extension of non-op care. We moved into stent grafting. This became commonplace, right? There's the proximal aortic injury treated with endovascular stent grafting. And this is the 2008 AAST2, as we called it, authored by Dimitri Dimitriadis, George Velmahos, and me. The first piece of work that demonstrated that endovascular care was associated with a highly statistically significant improvement in mortality. Now, it continues, and frankly, we began experimenting. These were case reports that people bragged about at the bar. Some were great cases, but there were one or two, and there was no real coordinated effort to advance the craft or even to collect data, and we kept learning, but I wondered what would be next. Here are two of my one-offs. This is a terrible posterior traumatic aortic injury just above the diaphragm. You see the celiac axis looks injured and the SMA looks stretched. And I looked at that and said, boy, that open is going to be so complicated. And we stent grafted it. The celiac and SMA turned out to be okay. It was the first case report of stent grafting for an aortic injury outside of the typical location. This is a young girl, 16 years old, on their way home from school when her Hyundai met a tractor trailer with expected results. This is an early CT scan. I had never seen contrast extravasation like this, and it goes right down to the cava. She had a blood pressure of 80, and I said, if I operate on her, she's going to die. And so first time I actually used hypotensive resuscitation, we ran her over. There's her angiogram. We embolized 4 injuries that looked like that. I took her to the operating room, decompressed her, packed her, brought her back the next day and did a right hepatic lobectomy. She survived. She graduated from nursing school and I hired her. Evolution becomes revolution, and it's a radical change. It's a drastic and far-reaching change in the way we think. Now, we clearly had something here, but the impediments to progress were really huge. We had little support from our own colleagues in trauma or anywhere in surgery. Institutions did not want to bite at this, and we needed a group to step out in front and a champion to lead us forward. And frankly, that was several groups, and it was me. This starts with a pivotal conversation I had with John Holcomb around 2010. And John said, "What do you think about bringing fresh frozen plasma to the desert?" And I said, "It can't be done." And he said, "It's not the question. Is it a good idea?" And I said, "Of course, it'd be fabulous." And he said, "Then we've made the decision. The rest of this is just about tactics." And I never forgot that. In 2013, the two of us convened a meeting in Houston to talk about catheter-based hemorrhage control. It's more than we have time to talk about today, but we talked about components to obtain competency, and then we crafted a set of recommendations. I'd give us about a B- or C+ for what we've done in 8 years, but we've made at least some progress here. It started with Reboa. And this is the earliest balloon that Carl Hughes used in Korea. The first Reboa was placed in Houston in December of 2012. We followed about 2 months later, and I'm in the operating room, and Megan is my first-year vascular fellow, and she tells me, and I'm sure it's true, I said, "Go grab that balloon thing and come to OR4. The rest ends up being history. 4 years later to the day, we presented our first 90 patients at the Pacific Coast. This is the first modern series of 6 patients. It's mostly blunt trauma. It turned out that the Reboa worked well. Time to get the Reboa in was 6 minutes. That's been the same every time we've looked at it. It was a bridge mostly to surgery, but also to endovascular care. And 2 people had care withdrawn, the other 4 lived. This is the current balloon, the Prytime, though there is now a newer 5 French catheter, so they keep getting smaller. What did we do? We created a course to train people, the basic endovascular skills for trauma course, now a COT course, and this is the data that shows that you can train people with some skills in a relatively short period of time. We have debated the use of Reboa since we started. Every time we've compared it to resuscitative thoracotomy, different patients, I understand, Reboa has turned out to be highly advantageous. And this, the Bilal Joseph TQIP data that says it's actually not any good and it's associated with an increased mortality. The debate continues to this day. Partial Reboa has become a popular concept, and this is some 2016 data that shows if you only partially inflate the balloon, you don't get the same blood pressure pop, but the ischemic insult is much, much less than it is with the balloon completely inflated. Now, this is the current data. It's the aorta database that Joe DeBose, with a little help from me, created. So we are collecting prospective data. And it's a little hard to know what to do with this because 40% of the Reboas are from 2 institutions. How does that translate to common practice, particularly when the largest number of people are putting in about 1 or 1.5 a year? Hard for me to know what to do with that. We remain convinced. We continue to enroll. Now, we tried to start interpreting this in a much more global sense. And this is 2015 AAST data from our institution where we confessed how bad we were. 5 hours to pelvic embolization, which is frankly embarrassing. And 80% of the deaths could be attributed to early uncontrolled hemorrhage. And I said, it's not okay. We're not going to do this anymore. One of my favorite slides from Dr. Shafton, who reminds us you have to create a safe environment in order to do this well. This is our institution. The resuscitation unit is 1.5 city blocks from the interventional radiology suite. And there is nothing lonelier than to be in IR at about 3 a.m. on Sunday with a really sick patient. And I'll bet you that that's true a lot of places in the country. What did we do? It's a cute story, but we built a new tower. There's the new shock trauma center. I horse traded the cardiac surgeons and got a hybrid operating room. And we went into business doing endovascular care 50 feet from the resuscitation unit, not at 1.5 blocks. The interventional radiologists weren't interested, so we hired 2 surgeons to start our endovascular program. That's Megan in the black scrub cap and Melanie Hain in the white cap. And we went into business. This is the first data from our own team. We did 9 patients a month, started slow, but we did well and there were no procedural complications. It's the standard smorgasbord of trauma, endovascular care, pelvises, TEVARs, splenic embolization, some filters, some extremity stuff, some stents. We did everything and they did beautifully. We expanded and started thinking much more broadly. We started doing things through a radial approach, which turned out to be highly successful and associated with statistically significantly fewer complications than was tradition, than doing everything through the groin. And this is the 2019 American Surgical paper that showed that doing it ourselves increased case volume and decreased time to hemostasis, particularly in the time-sensitive regions. There is the increase in volume, and we had over an hour, and in some cases 2-hour decreases in the time to hemostasis for pelvis, liver, and extremity, the ones that are time-sensitive. We expanded and started doing truly hybrid procedures. A couple of examples, I got a call, they said, oh, this 18-year-old kid's playing football, he's got the worst liver injury I've ever seen. I rolled my eyes, I said, how bad could this be? It turned out it could be really bad. There's a very high-grade injury with a big blush in the central portion of the liver. Johnny Morrison and I do him tag team. We explore him, we decompress him, we embolize him. He does great. And 2 months later, his liver is healed. It's a Baltimore series, so it wouldn't be one without a gunshot wound. Here's a guy with multiple gunshot wounds. And you can see he's got an innominate artery pseudoaneurysm and a high-grade liver injury. He gets a combination laparotomy and stent graft for his innominate artery. One-stop shopping. He does well with a single procedure. The liver has become a particular source of interest to us. We now have a bridge balloon to control hepatic venous injuries, and so we can wire everybody for sound, right? A zone 1 Roboa, a bridge balloon, and if you open a Pringle maneuver, gets you total vascular isolation with really very little in the way of dissection. This is one of the early bridge balloon patients, a young girl with a grade 5 kidney, a high-grade liver injury all the way to the cava, and a splenic injury. She gets the bridge balloon, the Roboa, an open procedure, hepatic embolization, like a hepatic resection with ligation of a hepatic vein, and she does beautifully. Now, all of that is great, but I began saying this endovascular stuff should be about resuscitation, not just creating cute pictures. And so we moved into an era where we tried to use these catheters kind of from start to finish. And so it's about creating stability. It's needs to be courageous and bold and dramatic. It's not about the emergency department. It's about creating a plan that treats a disease and the disease moves through various phases. It's about treating shock. And we need to challenge the status quo. And I'm going to tell you, I think that endovascular care is at the very center of that discussion. This is data from Vietnam from Peter Saffer and Ron Bellamy, and they demonstrated that many of the deaths were kids that were killed in action, and nothing is going to prevent that other than not going to war or better equipment. But there was a cadre of 30 or 40% where if we could do something, we could buy some time and maybe do better. This is Dr. Saffer's laboratory data in a large animal model, and he demonstrated that if you quickly produced hypothermia, and I mean like 10, 15 degrees hypothermia, that these animals would tolerate between an hour and 2 hours of cardiac arrest and wake up neurologically intact. And I said, that's crazy, except it's not. And this has gone through rigorous discussion. And we are now 5 patients into our series of EPR in Baltimore. Sam Tischerman, as you see in the picture, is the PI. We recruited him from Pittsburgh, and we have moved into a different era. We've learned a huge amount in 5 patients. It turns out that cooling them is really simple. It's not that elegant. It's a cross clamp. It's retrograde perfusion. But manipulating the coagulation system on cardiopulmonary bypass turns out to be really, really complicated. And so we are now getting ready to again start recruiting. COVID put a real crimp in our ability to do this. But I will tell you, number 5 came off bypass with a blood pressure of 120/80 and a heart rate in the 90s. And we were so close. So stand by, here we go. There are other ways to do this. This is selective aortic arch perfusion. This is a very proximal aortic balloon in a large catheter with a lumen that allows us to perhaps do EPR through a catheter. It allows us to give blood or other oxygen carrying compounds directly to the coronary arteries. It lets us deliver drugs directly to the heart. And so maybe the new generation of how it is we're going to do this. Now, is there a problem? The answer is yes. This is John Harvin data from 2017, and it turned out that the mortality from trauma laparotomy was exactly the same as it was in the mid-1980s when John Clark reported this. Our results are not one bit better. And it's about delivering the patient quickly and getting shock controlled early. And you can't tell me that telling the EMS people to drive faster is going to be the answer. We need a new way to do this. Here's his data. You can see that the mortality is largely from hemorrhage in people with shock. This is not a huge surprise. But, sorry, in the patients that have hypotension, there is a huge variability from institution to institution. That's kind of crazy. We need to smooth this out. And the problem is that we refuse to attack this as a problem, as a system. We fight about who owns the case. We fight about who owns the wire, and mostly we fight about who's going to get the money. We ignore the patient and the need to deliver patient care in a system. Leaders in our own trauma field have badmouthed the technique with minimal knowledge, and people have become self-proclaimed experts who have never actually done this in a human being. We fail to have societal or institutional commitment. We have 1,000 ways to get to zero. Now, we became interested in ECMO. This is pre-COVID ECMO data. And in trauma patients, our VV ECMO data suggests that the survival is about 70%. It's really pretty good. And I'm going to tell you that I think that ECMO is a resuscitation tool. It's not about respiratory failure. It's about unloading the right side of the heart. And we have really begun to use this earlier and earlier in people with terrible cardiac function. And we have asked the question, can we push this outside of the hospital? We can, and we are getting ready to do this. If the Europeans can do it, by God, we can. There they are cannulating for somebody for ECMO on the floor of the Louvre. Great museum, fabulous concept. And there's the VA ECMO data from Dusseldorf, where the survival was about 50% for field VA ECMO. And almost every survivor had a good neurologic outcome. Very impressive data and institutional and societal commitment. So we come to resolution then. What will be the answer? What will be the solution here? I'm going to tell you that I think that what we have is this arc of resuscitation. It starts with global hypotension and open hemostasis, the old way. It goes to permissive hypotension, ROBOA, perhaps partial ROBOA, selective aortic arch perfusion, EPR, ECMO, and ultimately it's a metabolic disease. It's about manipulating the metabolism that will get us to where we need to be. So welcome to the world of endovascular resuscitation. It is here and it will continue. Now, who's going to do this? There are 13 surgeons, as far as I know, that are trained in trauma, critical care, general, and vascular surgeon. One of them, KJ, is in the audience here that we were delighted to help train. And you have to know about the trauma part. If you don't do injury, then you don't really know what it is that we need to do in order to make progress. And I'm pleased to see that 10 of those people are either at Maryland or came through Maryland. We intend to continue to be the epicenter that bangs on this drum. We have a curriculum to train people in this technique. And you can say it's a bad idea or a good idea, but with our current volume, we could take 3 fellows, train them, and they would have sufficient experience to meet the volume requirements for vascular surgery or interventional radiology. It can be done. We can argue whether it should be done. And this is the current endovascular team. It's Johnny Morrison, it's Rishi, it's me as the cheerleader, Joe DeBose, who just left, and Anna Romagnoli, who will join us in a year, and then KJ and Mike Hall and Chuck Fox. It's a big team, and we love having everybody around. When it was just Johnny and Joe, it was J&J Plumbing. When Rishi came, we needed a new name, so it's now become Lazarus Plumbing as we rise from the ashes. Noli temere mezorum. Do not be afraid. Don't be afraid. Here is some of the new stuff. This is the first patient that came in with a popliteal injury, a threatened leg, and prolonged ischemia. And in the resuscitation unit, we cannulated her for retrograde perfusion through the posterior tibial artery as a bridge to a wire solution to the popliteal to revascularize her more quickly with a plan, a posterior approach for definitive care in 4 to 6 weeks. This is our sock and sleeve technique, a pelvic or aortic injury in a contaminated field. that is treated with open repair and then a stent graft inside the open repair to protect the suture lines in case there is suture line failure. We're about 7, I think, cases into this. Results are very, very encouraging. Just an angiogram of this. This is coming. In fact, it's already here. This is data from 2018. TVAR has replaced open aortic repair. It just doesn't happen anymore. It's moved down to the iliacs. And this is our data from several years ago where the amputation rates with endovascular care are highly better than they are with open repair. This is NTDB data. You can see that the rate of endovascular care in general continues to go up. This is prove-it data where you can see that now with blunt non-compressible hemorrhage, 80% of people are treated with endovascular care. 80%. And while the open patients were sicker, there was less transfusions and less mortality in the patients that had endovascular care. How far could this go? Well, it's already down to the popliteal as definitive care. Is that a good idea? Not a lot of data, but as the stents get better, I am certain that that progress will continue and we'll get there at some point. I have to pay respect to Mike Rotundo. This was his title slide when he came and gave our named lecture on damage control. It was revolution, rejuvenation, recapitulation. I borrowed this from him for evolution, revolution, resolution. I learned a huge amount from Mike. So the opening, or maybe in this case, not the opening, exploration and repair of living human bodies is an awesome responsibility afforded to only a few. To be privileged to be counted among those is a high honor surpassed only by being trusted to teach others this demanding and marvelous craft. This is a quote from the late Roger Sherman, and I couldn't think of anything more appropriate to use to summarize. This is a 1995 picture of Jerry Shafton with his wife at the COT meeting. I want to dedicate this to Jerry. Jerry was my friend, my mentor, my hero. He died 2 years ago. And Jerry, I hope what we've done has continued to make you proud of me. If it hasn't, I sure have tried. So this evolution, revolution, resolution is a 35-year story. I was lucky enough to be there from the beginning. I think this is fascinating. I hope you do too, but we've never embraced it as we should have. It's not fantasy. This is real. And we need to understand history to chart the future, but we can't let others do this for us. I'm really grateful to all the crazy people that were willing to dream with me. And this is now me handing off to the next generation. I'll be the old guy sitting in the corner. There's a career here for any young surgeon that wants to grab this and run with it. And by God, I hope you do. And if you screw it up, I will haunt you. I promise you. I'm really grateful for the opportunity. Dr. Richards, thanks so much for allowing me to come to a place I really consider home and share some thoughts with you. Thank you very much.
That was an amazing, fantastic lecture. And thank you for including that quote from Dr. Sherman. This is the plaque for giving the Roger T. Sherman Lecture 2021. Dr. Scalea.
Thank you.